I am Dr. Sharjeel and you are watching my YouTube channel Sharjeel I. If you like my videos, don't forget to subscribe my channel and press the bell icon so that you should not miss the regular interesting videos. Now today I am solving the ophthalmic science 2 case, and this 6 years old kid was brought to me by parents with complaints of decrease of vision, both eyes. When I asked how you come to know that he has got decreased vision, they told me that he watches the things very close to the eyes. When he watches the television, he is very close to the screen. So as myopia pandemic is on the rise, I thought this kid is also having high myopia, because the symptom that keeping the things very close to the eyes to see, that's a ready-made symptom of myopia. And as we all perform cycloplegic refraction in kids, so when I dilated him for cycloplegic refraction and performed refraction, he had -6 refractive error, and with -6 he was becoming 6/9 both eyes. So he was not having any amblyopia, and you should know that amblyopia is more prevalent in hypermetropia and not in myopics. And as we all know, in myopes you have to examine the fundus as well, especially if the patient is high myope. So when I performed his slit lamp examination, I got surprised because I can see the whole crystalline lens, the whole equator along with zonular attachments in a fully dilated pupil. So I came to know that the patient had microcrystalline lens, and there are two conditions that come into my mind: microphakia and microspherophakia. Now in microphakia, now how to differentiate these two? In microphakia, lens will be smaller in diameter but not globular, so it will be a weak lens and the patient will not be myopic. The patient will either be hypermetropic or could be emetrope. So it means our patient is having microspherophakia because the lens is smaller in equatorial diameter but spherical or globular or round, that make him more powerful and myopic. Now another question arises: how to confirm microspherophakia? Well, its characteristics are that it's a genetic condition and it will present by birth, and it will be bilateral, and there will be increased anteroposterior diameter that give it a spherical shape, and decreased equatorial diameter that will give it a micro shape. And when patient is fully dilated, you will be able to see the whole equator, and you will get the shining outline of the equatorial lens. As you can see in the video, there will be a slight phacodonesis, movement of the lens with movement of the eye. You will get myopia, you will get defective accommodation with it, because the zonules are defective. There is a problem with the zonules, that's why the lens is globular, and you may or may not get lens dislocation, subluxation, and one of the common associated ocular feature is secondary angle closure glaucoma, pupil block glaucoma. Now you can get microspherophakia as a separate entity, or it can be associated with ocular conditions like aniridia, megalocornea, optic disc colobomas, eyes syndrome. So there was no associated ocular signs. It was an isolated microspherophakia, and then systemic conditions are also more commonly present with microspherophakia. Now, what are those? These are Weil-Marchesani syndrome, Marfan syndrome, Lewis syndrome, homocystinuria, Alpert syndrome. These are the few common ones. There is a long list, but you should remember those. So, our patient was an isolated case of microspherophakia. And now the question arises that why it occur? Well, there is a defect in the suspensory zonular fibers and lack of tension and arrest in lens development, the secondary lens fibers. So, lens remain in spherical shape. There is arrest in development of secondary lens fibers in the 5th 6 months of embryonic life that lead to spherical shape instead of converting to normal biconvex shape. So, that was microspherophakia. And now, how to manage such cases? Like, one thing is that this patient was having normal intraocular pressure. You have to keep in mind intraocular pressure, cataract formation, and refractive error, or if they get amblyopia, then you have to treat that. So, prevalence of glaucoma increases with age. Like, this is a kid, so we have to regularly follow up this kid. Usually secondary angle closure glaucoma occurs, so the treatment of that is you should perform laser peripheral iridotomies, clear lens extraction, trabeculectomy, and shunt procedures. These are the options. Now, when you have to perform a clear lens extraction? Well, if patient have lenticulocorneal touch, the lens can cause pupil block, and it can come into the anterior chamber and touch the cornea as well. So, then you have to remove the clear lens to keep cornea from decompensation and to prevent pupillary block glaucoma. For myopia, you have to give glasses and cycloplegics. Now, cycloplegics have dual effect. Number one, it deepens the anterior chamber, moves away the lens iris diaphragm from the cornea. It stops myopia progression. And remember, don't put myotics in these kids' eyes, because it will precipitate acute ankle closure attack. Now, keep in mind, as I said, that you have to perform clear lens extraction or cataract surgery in these patients. You can encounter difficulties while performing such surgeries, especially in rexes. The lens is moving and it is a small, and the zonules have got given a poor support. So, perform large capsule rexes very gently. Put smallest size capsular tension ring. Perform phaco with low vacuum, low power, low fluidics if cataract. Otherwise, very gently lens matter aspiration with IA mode and implant foldable IOL. So, that's how you manage cataract surgery in microspherophakia, and I hope after watching this detailed video, you will not forget microspherophakia. And take home message is that always when you see high myopic kids, always dilate the pupil, check fundus, and you may get this condition as well. Thank you very much.